Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Jervis Constanzo. Today's episode features Dr. Isabelle Ray-Coquard from the Centre Léon Bernard of the Université Claude Bernard in Lyon, France, and Dr. Ana Oaknin from Vall d'Hebron University Hospital and Institute of Oncology in Barcelona, Spain. They will be discussing new clinical trial data for endometrial, ovarian, and cervical cancers that were presented at the 2023 European Society of Medical Oncology, ESMO, Annual Congress, held in Madrid, Spain. This episode is part of a larger educational program entitled Key Findings and Expert Recommendations in Gynecologic Malignancies, Independent 2023 Conference Congress coverage. For more information on Dr. Ray-Coquard and Dr. Oaknin, along with a link to the complete program, including a downloadable slide set and clinical commentaries, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say about the key data presented at the 2023 ESMO Annual Congress.
Hello, my name is Isabelle Ray-Coquard. I'm a medical oncologist, professor of oncology, the president of the Gyneco Group. I'm working in the Centre Léon Bernard and University Claude Bernard in Lyon, France. It's my great pleasure to be joined today by my distinguished colleague, but also very good friend, Dr. Ana Oaknin, who is a professor and head of gynecologic cancer program at Vall d'Hebron University Hospital and Institute of Oncology in Barcelona, Spain. Welcome, Dr. Oaknin.
Thank you, Dr. Ray-Coquard. It's really my great pleasure to be here with you today.
Today, we will be highlighting for you data from key studies that were presented at the 2023 European Society of Medical Oncology Congress for Gynae Cancer in Madrid, Spain. We will share with you our view, opinion, and takeaway of key data presented live for endometrial, ovarian, and cervical cancer. Some with the potential to change the current practice, including for the phase 3 ATEN trial of the addition of atezolizumab to carboplatin paclitaxel with or without atezolizumab maintenance in advanced or recurrent endometrial cancer, but also the phase 3 DUO-E trial of the addition of durvalumab to carboplatin paclitaxel followed by durvalumab endometrial cancer, but also the phase 3 KEYNOTE-A18 evaluating pembrolizumab with recurrent chemotherapy and radiotherapy in patients with locally advanced cervical cancer, the phase 3 of induction chemotherapy followed by chemoradiation therapy versus chemoradiation therapy alone interlaced, and also the BCC trial reporting the efficacy of atezolizumab in combination with bevacizumab and chemotherapy in advanced relapse cervical cancer. I will start with endometrial cancer, and I will immediately move in the ATEN trial. It is an ENGOT-GYN lead trial. We explore this efficacy of atezolizumab, a PD-L1 inhibitor, in combination with the standard of care carboplatin paclitaxel for patients with advanced, newly diagnosed, or recurrent endometrial carcinoma. This patient received this combination in this large phase 3 randomization 2-1, and we explore the PFS as the primary endpoint in the dMMR population, followed by the PFS in the ITT population, and overall survival are also a primary endpoint. In terms of patient characteristic, it is what we anticipate in this population. There is close to 25% of patients with a dMMR status. The majority of the patients are in the recurrent setting. The majority of the patients were naive of prior chemotherapy. And in terms of representativity, there is several histology possibly included in this trial, including carcinosarcoma, but also clear cell carcinoma undifferentiated. We have seen also that in this trial, we have close to 20% of the patients with population. And they also explore the PD-L1 expression in this population 25% of the patients are PD-L1 positive, but also ARID1. The primary endpoint was the PFS in the dMMR population, and we see another ratio of 0.36 in the population with a great benefit for the combination. Looking to the all-comers population, again, the other ratio is positive with another ratio of 0.74. Also, we have a median follow-up of 28 months in this clinical trial. The data considering the overall survival in the dMMR population is also positive with another ratio of 0.41, and meaning that we are able to avoid 60% of deaths using this combination in this particular population. In the ITT population, the overall survival, the other ratio is 0.82 and did not reach the statistical significance. Also, the data maturity is only 43%, and we see that 25% of the patients in this population receive immune therapy in the subsequent lines of treatment. In terms of exploratory analysis, the author report the pMMR results for PFS and OS, and we don't see a huge benefit to add atezolizumab in this population of patients. Looking to the response rate and the duration of response, again, the results were particularly evident in the dMMR population in terms of response, but more importantly, in terms of duration of response. In the pMMR population, there is no difference in terms of response rate or duration of response. The analysis in the subgroup for PFS report activity in the majority of the subgroup with a huge efficacy in the dMMR population. And looking to the overall survival, again, the majority of the subgroup are in favor of the combination compared to chemotherapy alone. However, the author notes that Asian population seems to have a less efficacy than the other population, but it is a subgroup analysis. We also see for overall survival a huge benefit in the dMMR population compared to a pMMR population, and also perhaps better efficacy in the PD-L1 positive population. Considering the safety profile, there is no significant information to report. It is what we anticipate with PD-L1 inhibitor. And finally, we have % of grade 3 and more treatment-related adverse events in line with the chemotherapy and in line with what we anticipate for this population. Now moving to the second phase 3, the DUO-E trial exploring durvalumab plus chemotherapy, followed by durvalumab plus or less olaparib as a maintenance therapy in the same population of patients. The primary endpoint in this trial is also the progression-free survival, and overall survival will be reported. The patient characteristics are what we anticipate in this population with 20% of dMMR. And in this trial, we see a benefit statistically and clinically significant to add olaparib and durvalumab to standard of care chemotherapy. Also, we see a difference between the maintenance, the duo maintenance versus durvalumab alone. The results were concordant in all the subgroup analyses, looking to durva versus control, but also durva plus olaparib versus chemotherapy. And in terms of subgroup analysis, we see that add of olaparib to durvalumab in the dMMR population did not seem to bring some benefit compared to durvalumab alone, that it is not the case for the pMMR population, which seems to be the best population to receive this dual maintenance therapy. In terms of overall survival, it is not completely mature, but we see a trend in favor of the dual maintenance versus the durva monotherapy, but we need to wait for more maturity to conclude. The safety is as we anticipate. Olaparib had more toxicity compared to immunotherapy alone. Also, it seems completely acceptable because at the end, we don't see so many patients who stop the treatment for toxicity. It's 10% in the maintenance setting for olaparib, 8% for durvalumab, and 40% altogether. Again, it is what we anticipate. We have more anemia, more neutropenia and nausea adding olaparib to durvalumab versus control. In terms of grade 3, as I mentioned before, we don't see something new in this population, and we consider that it could be interesting, particularly in the pMMR population or more detailed subgroup we can discuss later. In ovarian cancer, we report the BOUQUET trial that it is a very innovative design dedicated to rare ovarian cancer who are particularly resistant to standard of care. And the patient receive a biomarker testing using FMI platform, and looking to the abnormality, we are able to receive several targeted treatment or combination. Today, they have reported the cobimetinib results and atezolizumab plus bev results. We see that the majority of the patients, including the cobimetinib, as we anticipate, low-grade serous, but also mucinous cancer patients. The safety profile of the cobimetinib in this trial is perfect. Is also the same for atezolizumab. Considering the efficacy of cobimetinib, we see some activity, particularly in the low-grade serous ovarian cancer and mesonephric-like adenocarcinoma, where we see that the duration of the control rate is close to 90% in this population, with a long duration of response. For atezolizumab, we don't see a huge efficacy in terms of response rate. However, we have to note that 75% of the patients are free of progression at 6 months using this combination, that it is something interesting in this population, particularly resistant to a standard of care. This is what I would like to share with you for endometrial and cervical cancer.
Thank you, Professor Ray-Coquard. I think you have really nicely summarized the key trials and the key data for the endometrial and ovarian cancer presented in the ESMO meeting. What is clear for me right now is that the endometrial cancer treatment landscape is rapidly evolving, and I don't think paclitaxel carboplatin will be the standard of care any longer. With this idea in mind, let me ask you two important questions. One of them is related with the ATTEND trial. We already learned from the RUBY and 018 that both dostarlimab and pembrolizumab improved the data from paclitaxel carboplatin. And in these two trials, the duration of maintenance therapy is limited to approximately 2 years for pembrolizumab, approximately 3 years for dostarlimab. However, in the ATTEND trial, the duration of atezolizumab is until progression or unacceptable toxicity. So the tricky question for you, do you really think that we should maintain our patients until progression or toxicity, or should we better give the therapy only for a fixed period of time?
It is a very smart question, right? Probably we have the opportunity to explore several options. Right now, it's not direct comparison, and possibly for patients with no residual disease in complete response, prolonging the maintenance therapy will be complex for the physician and also for the patient. However, for patients who will have stable disease, probably will be in favor to maintain the pressure using immune therapy. But I agree with you, right now using immune therapy, a fixed duration of maintenance will be for sure interesting for the patient.
Thank you. Another important question, I think that is also another tricky question. So you have shown us in the DUO-O that I would like to remark that is the first trial that report data incorporating a PAR inhibitor as maintenance therapy in endometrial cancer, phase 3 randomized trial. So you have shown, and in the pMMR, there's a benefit to adding olaparib to durvalumab to paclitaxel carboplatin compared with the standard of care with a hazard ratio 0.57. Do you think that upon regulatory approval, olaparib plus durva plus chemotherapy should be the standard of care for all those patients who are pMMR? Could you elaborate a little bit that?
It is a complex question you ask, Anna, because in the trial, the pMMR is the stratification factor. Also, pMMR is finally a negative biomarker. That means you are not dMMR. And in this basket, we have a lot of differences. We have P53 mutated patients We have NSMP population. We include ER positive, ER negative patients, and possibly we can be able to upgrade the quality of the definition of this subgroup of patients. And what we have seen with UTOLA is that P53 is probably interesting to be more selective in this population. Perhaps an homologous recombination deficiency test adapt to endometrial carcinoma could be also something interesting in the future. But I agree with you, this pMMR population continue to be an heterogeneous population. So I don't know at the end what the authorities will decide, because right now it is the stratification factor, but I will be personally in favor to continue to work on that to better define this population.
Thank you, Ray-Coquard, for answering my question in a very clever manner. So now it's time to move to cervical cancer. I would like to say that this year in ESMO 2023 has been the year of cervical cancer. We have 2 phase 3 randomized locally advanced cervical cancer and 2 important trials in the recurrent metastatic cervical cancer. I will start reviewing the trial developed in the locally advanced setting, just in order to set the scene. As very well, the standard of care that we have right now in our daily practice was established in 1999. So since then, there's no advances in the treatment of locally advanced cervical cancer. So I think we can congratulate all the authors for bringing this new data. So let me start with the trial keynote AAT, ENGOT-CX11, GOG347. This is a phase 3 randomized double-blind placebo-controlled that enrolled in patients. You see a large number of patients. The key characteristic of this trial is all patients were considered high risk locally advanced. Why high risk? Because all patients must have either positive lymph node, either pelvic or para-aortic positive lymph node, or stage 3 and 4A. Then the patients were randomized to a standard of care, as you know very well, concurrent chemoradiation, weekly cisplatin with radiotherapy plus brachytherapy, or experimental arm. The experimental arm was adding pembrolizumab concurrent with chemoradiation, followed as pembrolizumab as maintenance for 15 cycles. Important primary endpoint, PFS by RECIST and overall survival. And then in order to understand this trial, once again, I would like to stress the population. The population is very important because in the keynote A18, the author enrolled a variety of population, a variety of races, white, Asian, American. It means that this trial, this outcome can be extrapolated across the world. In addition, the PD-L1 status is always a key point to discuss in cervical cancer trial. And what have we learned from the keynote 18? That 94% of the patients had tumor PD-L1 positive. So this raised the question whether PD-L1 status is really a good biomarker, but it's not the point here. And then the number of patients with positive lymph node was approximately 80%. It means a high risk population. And so the outcome was very nice. You know, the first time in a long time that a trial showed an improvement in PFS for this population. When you look at the 24-month rate, it was 57% patients were alive and free of progression in the standard arm compared with 67.8% in the experimental, an improvement of 10%. But I would like to stress that the median PFS has not yet been reached. It means that we need still a longer follow-up to see better outcome, because right now the median follow-up is around 18 months. What about the overall survival? Overall survival is a very important co-primary endpoint in the locally advanced setting. In the keynote 18, they show a positive trend because the data are still very immature. And you know very well that with immunotherapy, we need long follow-up in order to get the benefits. So I am still positive that the overall survival will be also positive for this trial. I only want to summarize that the addition of pembrolizumab to the concurrent chemoradiation didn't jeopardize the standard of care, the use of weekly cisplatin with radiotherapy. The main concern was the incidence of diarrhea. And then when we see the treatment-related adverse event, we saw that the incidence of diarrhea was similar in both. So the other important trial, the Interlace trial, I think is key to understand the differences between in the two trials, because now we are facing a new standard of care in this setting, and we need to determine which patients are better for one approach and for another approach. What about the Interlace? Interlace established the induction chemotherapy. It means 6 doses of weekly paclitaxel and carboplatin previous to concurrent chemoradiation. But what about the population that was enrolled in the Interlace trial? It was a population that we cannot define high risk locally advanced. It was locally advanced, but not all patients had positive lymph node. Indeed, when we look at the patient baseline characteristic, 57 of the patients were negative in terms of lymph node. They didn't have positive lymph node. And another important point, in the previous trial, I said that the author include a lot of a variety of races. In this trial, Interlace, 75% of the population came only from United Kingdom and 20% from Mexico. So then the patient received 6 cycles, weekly cycles of paclitaxel carboplatin, and then the patient were receiving concurrent chemoradiation. It was the experimental arm, and the standard arm was concurrent chemoradiation. Another key difference with the KEYNOTE-18, only 500 patients were randomized. The good news that the trial was also positive. The addition of induction chemotherapy improved PFS with a hazard ratio of 0.65. And in addition, very important as well, the trial showed a positivity in terms of overall survival with a hazard ratio 0.61. And let me tell you something, a difference with the KEYNOTE-18 is that the Interlace trial had a longer follow-up, and they have been able to report the overall survival rate at 5 years. And it was 72% for the concurrent chemoradiation and 80% in the experimental with induction chemotherapy. So two positive trials that are going to change the standard of care in the locally advanced cervical cancer. Unfortunately, still patients relapse, and then we need to provide them with an effective systemic therapy. We have learned in ESMO the BCC outcome. The BCC trial is an NJGOG 10A4 GOG 3030. So the objective, the BCC trial, was to determine if the addition of atezolizumab anti-PD-L1 therapy to a standard of care established by GOG 240, namely bevacizumab plus chemotherapy, will improve the outcome of our patients. So we randomized 410 patients with metastatic recurrent cervical cancer with a good performance status, and they were randomized standard of care GOG 240 arm plus atezolizumab in the experimental arm. Important co-primary endpoint, PFS and overall survival. When we look at the baseline characteristic, is the typical baseline characteristic in the first line trial for cervical cancer. Approximately 20% of the patients had metastatic disease at the study entry, and the rest of the patients had recurrent or persistent disease. Then, with a median follow-up of approximately 32 months, we are able to show as the addition of atezolizumab to chemotherapy plus bevacizumab improved PFS with a hazard ratio 0.62, and importantly, also improved overall survival with a hazard ratio 0.68. And let me tell you something, when you look at the overall survival and 24 months, it was 61% patients were alive with the combination of atezolizumab plus bevacizumab chemotherapy compared with 49% in the standard arm. And when we look at the results according to subgroup, as you can see, the benefit was consistent across important subgroups, taking into account the disease state, chemotherapy backbone, and histology. And another important point is the safety summary. The addition of bevacizumab didn't increase the side effect compared with control arm. Mainly when you look at the rate of discontinuation was 15% in the atezolizumab arm compared with 16% in the control. This is first-line therapy, but what happened when the patients progress after platinum-based therapy? Then we need to look for new option. And then in ESMO, the phase 3 INNOVA300-01 has been presented. In this trial, the investigator compared the standard of care chemotherapy with the antibody-drug conjugate tisotumab vedotin. As in the phase 2 trial, tisotumab vedotin showed promising overall response rate and PFS, and this is the reason why this randomized trial was launched. I would like to point out in terms of patient baseline characteristics that approximately 27% of the patients had previously received immunotherapy. This is very important because, as we have seen, we are moving immunotherapy either to locally advanced or first-line therapy. So having this population included in the trial is very important. And in addition, the number of previous lines of chemotherapy in the trial was approximately 60% of the patients had received only one prior line of therapy. So what have we learned from this trial? We have learned that tisotumab vedotin is superior to chemotherapy in terms of overall survival with a hazard ratio 0.7. It means that they reduce the risk of death in 30%. One thing that we should stress regarding tisotumab vedotin is the safety profile. There's adverse event of a special interest related with tisotumab vedotin, that is the eye toxicity or eye ocular event. So this something that we should mitigate, implementing a specific measure as eye drop before the therapy, eye cold pack before the therapy, and during therapy in order to reduce these events. But the bottom line is that the trial was positive and showed an improvement compared with chemotherapy. The result for chemotherapy after platinum therapy was very poor. So this is the main data from cervical cancer. I expect that you have been able to retain all this information. Thank you.
Thank you very much for your marvelous summary, Dr. Ana Oaknin. I have two questions for you for the important results you bring to us. First of all, considering the relapse setting, as we have the access to cemiplimab for patients post-platinum-based chemotherapy, adding Bev, how do you organize the choice of the second treatment for cervical cancer? Now we have seen the TISO results.
Thank you, Professor Ray-Coquard. I mean, this is a very important question. The first thing is that in the cemiplimab trial, all patients were naive for immunotherapy. It means that the patient have not received previous IOs. If the patient has received previous IO in a clinical trial or in the daily practice, there's no doubt that one option is to receive tisotumab vedotin after progression. But those patients who have not received IO, this is the key group of patients. Honestly, I think that the outcome for immunotherapy in cervical cancer, and when we look at the shape of the curve from the cemiplimab trial and tisotumab vedotin, it seems that the effect of cemiplimab, we say, lasts longer in a better way. So then I think that I should try firstly cemiplimab for those patients naive and secondly tisotumab vedotin. The only group of patients for which I would start with tisotumab vedotin will be those patients who need a quick response, because as you know very well, immunotherapy takes longer to screen the tumor. So then in this group that needs a rapid response, I would start with tisotumab vedotin.
Another question, moving to the first line setting in the locally advanced, you report the CX11 A18 results, but also the Interlace phase 3. How do you imagine the future? We combine the data to define the base standard of care for cervical cancer patients. Are they the same patient included in both trials?
Yeah, a very good question, very important. So as I summary, in Interlace trial, 57% were negative ENGOT. It means that there's a population of less risk compared with the keynote 18. So until we read and we review the paper for Interlace and we will learn what happened with the group of patients with positive lymph node, I think that for in the daily practice or for regulatory approval for patients with either pelvic or para-aortic lymph node, they should receive pembrolizumab as part of the concurrent chemoradiation. What happened with those patients who are not positive lymph node and they are stage 2 and stage 1B? These patients were enrolled in both trials, so then we need to see the subgroup results in order to determine what will the best approach. Because when you look at the forest pros for the keynote 18, this group of patients seems not to have the same benefit compared with those who are positive para-aortic or pelvic lymph nodes. So I think, the key point in order to determine what is the best approach is the positivity for the lymph node. But for sure, I would like to review the paper for Interlace because I think that there's still missing information that we need to have in order to determine which group of patients will benefit most from having chemotherapy as induction therapy.
Thank you very much for your answer, Dr. Oaknin, and I agree very much how I think about this trial. Thank you also for this great discussion today. It's always a pleasure to have some discussion with you and the clarity of what you are saying. Before we leave, I want to remind the listener that the slides associated with this discussion on key new data presented at the 2023 ESMO Annual Congress are now available on the CCO website. I hope our listeners have found this discussion educational and entertaining, and that it can help to inform their clinical practice. Thank you for joining us, and goodbye.
Thank you very much, Dr. Oaknin and Dr. Ray-Coquard, and thanks to you, the listeners, for joining us today. As a reminder, review the full program, key findings, and expert recommendations in gynecologic malignancies, independent 2023 conference congress coverage, and to download a highlights slide set, including the various studies associated with this discussion, please click on the link in the show notes. As always, thanks for listening.